Okay, if we could play Carl Cohen's video.
Hi, I'm Carl Cohen from the Division of Geriatric Psychiatry and the Center of Excellence for Alzheimer's Disease at Downstate. Today I'm going to talk about the heterogeneity in Alzheimer's disease, its course, neuropathology, and race, and how these are potentials for research. I have nothing to disclose. Over the years, we've gotten some funding from various federal agencies, as well as New York State Department of Health, and as well as the Alzheimer's Association. I want to begin with a brief overview of the typology of cognitive impairment in older adults. All of these are potential points for research and clinical interventions. So first, there's normal cognitive aging. As people age, they will show some cognitive declines versus younger people, but they show no impairments in daily functioning. Subjective cognitive impairment is when older adults show subjective complaints of memory problems or other cognitive issues, but there are no objective impairments when tested based on age. This group perhaps shows an increased risk of dementia, perhaps 10%. Mild cognitive impairment, there are objective deficits on testing. They score usually at least one standard deviation worse than the general population of older adults, and they do show a higher risk for dementia, perhaps 33% to 50%. But like the other groups I've mentioned, they show no impairments in daily functioning. Now, this is opposed to people with dementia, Alzheimer's being the most common, but there are other types, vascular Lewy body mixed, where they show impairment in daily functioning, and on objective testing, they're worse than approximately 95% of other people, 2 standard deviations below the norm. Now, what I wanted to address specifically today are 2 key points. Alzheimer's disease is heterogeneous with respect to course and neuropathology, and there are racial differences in prevalence, neuropsychiatric symptoms, and caregiver burden of Alzheimer's disease. With respect to heterogeneity, I wanted to first begin by showing you a typical slide where you see a group average with a steady decline in cognitive functioning over time. This was 5 years in the study. We found, using a national data set, there's actually more nuance to this. There's one group of fast decliners, about 33% of the population or sample, that shows a rapid decline. There's another group, about 31%, that shows a slow decline, but clearly a decline. Then there's a group of people who what we call zigzag stables, that they go up and down, but after 5 years, they're pretty close to their original values in cognitive functioning. That's about 16%. There's another group of people who are stable, who show very little fluctuation in their cognitive functioning over 5 years. And finally, there's a small group of improvers, about 5%, that actually improve over time. The stable group and the improvers may perhaps represent one group. But overall, you can see there's about a 37% chance of ending up in a group that doesn't show much changes over time. The risk for being in a particular group, women show much higher risk of being in the fast decliners, whereas people who have traumatic brain injury actually show a much greater chance of being in a stable group. And people who do not have an ApoE4 allele are more apt to be in a stable group. Which leads to the next slide, which shows that some of these differences may be accounted for by differences in pathology. This shows actually racial differences in pathology in people diagnosed with Alzheimer's disease. And on postmortem, we find that among blacks, only 20% roughly have Alzheimer's disease alone, and over 70% have a mixed pathology. Similarly, among white people, it's about 42% show Alzheimer's disease alone, and 51% have a mixed pathology. This is a good segue into the next section, which I wanted to talk about, which are racial differences that exist in prevalence, neuropsychiatric symptoms, and caregiver burden of Alzheimer's disease. There are significant racial differences in the prevalence of Alzheimer's disease. Rates of Alzheimer's disease are found to be roughly 2 to 3 times higher in African Americans and about 1.5 to 2 times higher in Latinos versus whites. And you can see from a study done in North Manhattan that, especially when you get into the older group, 75 and over and 85 and over, the differences between races are quite dramatic. Why this occurs is not entirely clear. One possibility is that neuropsychological testing is affected by education, class, and culture. Another possibility is the study design affects these findings. If you do cross-sectional studies, you find marked racial differences. But if you follow particular racial groups over time, you don't necessarily see differences. For example, our trajectory studies show no racial differences over time. Moreover, studies looking at age-related cognitive declines have not shown necessarily racial differences as well. Neuropathology differences may be more marked multiple pathologies in Alzheimer's disease, as suggested in the earlier slide by Barnes et al. And there are mixed findings regarding biomarkers. As you can see from this slide, if you're looking at things like beta amyloid and tau, abnormal tau, you can see that there are higher rates among blacks in some studies, lower rates in others, and no differences in some other studies. Another thing that we see is racial differences in neuropsychiatric symptoms. Our group found that psychosis and agitation are higher among blacks than whites, whereas depressive and anxiety symptoms seem to be higher among whites than blacks. Now, it's not clear what the cause of this is. One may be when people present at what stage of their illness. Another may be concurrent medical conditions. Another possibility may be coping strategies that people use, culturally based coping strategies to deal with changes in their cognitive functioning. And finally, biological risk factors may play a role. There are also racial differences in caregiving with Alzheimer's patients. African American caregivers report fewer depressive symptoms and lower perceived burden than white caregivers, and actually report a more positive caregiving experience than white caregivers, despite the fact that objective measures suggest that African American caregivers are have more actual burdens in some ways. What it's clearly demonstrated in the literature is more data are needed on minority elderly. This is a potential point for translational research. I would suggest that we could do tracking trajectories in African Americans, African Caribbeans, Latinos, and Caucasians in various cognitive states, both normal cognitive aging, subjective cognitive impairment, mild cognitive impairment, and dementia, using various biological, clinical, and social measures. For example, measures of neuropsych testing, biomarkers, genetics, neuropathology, neuroimaging, neuropsych symptoms, physical health, social cultural measures, and impact of clinical interventions. So I'm going to stop with this, and again, these are all points for important translational research that we could be doing at Downstate. So thank you for your attention.
Thank you, Carl, wherever you are.